Good afternoon. This is Dr. Mehta. I am the course director of Lumen Global, and we are continuing our series of chats at Lumen Global. We've just completed day one of the first session, and I am honored and privileged to have Dr. Shirish Hiremath join us. For his description, the title would be an immediate past president of the Cardiology Society of India and the director of coronary interventions at Ruby Hall, which I've been privileged to visit on numerous occasions. The conversation will take about 20 minutes, and it covers relevant areas of STEMI interventions in India, and of course we'll draw conclusions about how those could be applied to the region. Shirish, we did all right on day one of Lumen Global?
Great. I really learned. I mean, I thought I know a lot of things about STEMI and primary angioplasty, but having so many experts thinking differently, coming from different parts of the world, it really was an excitement for me. As you've been telling us again and again, it's not the intervention cardiologist alone who is the key person. Everybody, including the ambulance driver to the rickshaw driver who brings the patient to the ER, is very, very important in time saving.
Absolutely. I think you are correct. It's all teamwork, as we have realized there, and there is a very defined role for every component, each individual involved in the STEMI food chain, as we may call it. And the role of the paramedics, the emergency room physician. Lumen Global this year in 2018, the Lumen Global Achievement Award has been given not to a cardiologist, not to an interventional cardiologist, but to an emergency room physician, Dr. Ivan Rokas. Not only has he taught us how to optimize pre-hospital management, but also he's navigated through the difficult issues which were confronting us almost a decade ago. So I'm happy about that. Shirish, why is it taking so long to make definite improvements in the ambulance structure in India? I have visited the 108 operations in Hyderabad. They look very earnest, yet when I go around and speak to people around the country, the problems with the ambulance do persist.
Yeah, I think that's one very weak link, I would say, in the country. I would probably be thinking in general why there is so much slackness at this particular point. But I would imagine we have to really activate everybody down the chain, and this is probably the base first point of contact. So probably people are a little bit slack. Maybe there is a little resistance from the family too in sort of moving the patient and so on. But I guess as we do more and more, this would get corrected.
So in the United States, it's a two-tiered system. Several ambulances, although a minority, are owned by the community and the city, and the funding of those comes from the taxes which every homeowner in the community pays. Beyond that are private ambulances, and I am just surprised. This can be not only a life-saving but a very profitable business. I am told that the ambulance systems in Pakistan are exceptional, and it's a private company which has taken it up. Why is that not happening in India?
I guess we need to follow the system, learn from them, and I'm sure since you're suggesting the CSI could get into it and make some strong suggestions.
Absolutely. And Shirish, the other reason I mentioned that is you come from Pune.
Yes.
The automobile hub of the country.
Yes.
It should not be too difficult for some enterprising person to get into the business of ambulances, and this we have noticed it. In the United States, ambulance companies privately run are extremely profitable.
You're giving me ideas, and I would
Yeah,
follow this.
yeah, I think that would be because that, as you have said it so eloquently, is the weak link, and let's hope that it gets addressed. And that's the first year is the ambulance. The next level, which Michel Lemay is an absolutely world authority, is how to train the paramedics. Because not having an ambulance is the first part of it. I think having a trained paramedic who's able to interpret EKGs, transmit EKGs, initiate pharmacology, provide life saving resuscitation if that is required, as well as the use of defibrillators are the other elements which I think are critical. And one of the reasons around the world, as the Lumen Foundation has been involved, we have realized that once the investment going into ambulance care not only saves lives from acute MI, but it even helps stroke and accident victims.
I would imagine the last part that you described, acute resuscitation for these patients. The team is generally geared for that. Interpreting EKG, getting easy with very rapid and quick transfer with mobiles, WhatsApp, and so on. I think that interpretation time is definitely getting better. I mean, most of the time we expect it to be less than 10 minutes, and I'm sure it's achieved. So I think that's one point where we are clearly saving time.
I want to go into a few other specific areas which I have observed at several centers in the country.
Before you go there, the pharmacotherapy is
Yes.
one which I think we need to explain in better details to this team, because I have very rarely seen lytics given in an ambulance. Then pre-meds, I think we are just with standard protocols. So maybe we could make some advance or some steps forward in this particular direction.
Absolutely, I think that's where the trained paramedics comes in. The facility at 108 was very impressive. I saw them communicate. The physicians at the center, at the command center, were communicating with the paramedics, and hopefully that system can be expanded. Moving on to another couple of areas, I have noticed some exceptional PCI centers in the country, and even at those centers patients are getting thrombolysis. That should not be happening, no?
I would entirely agree on that. I think this is, unless the patient or the family is not ready, I think that happens not just occasionally, but many times in India. The mindset is a little bit of an issue. The trust level is never the best. When they come as an acute case, they don't know the doctor, they don't know the hospital. And in India, the practice many times is not regional, like a patient has gone to an X hospital when actually he's been following with a Y doctor somewhere else. So the trust level is sometimes not the best, and that's why they're not probably willing to accept. But I mean, clearly in 2018, both you and I know that primary angioplasty is the way to go.
Moving on to another challenge in India, a lack of STEMI networks. I want to understand with you with complete candor here, is that not happening because of lack of ambulances? Is it not happening because of a hyper competitive atmosphere? Is it not happening because of the trust of the patients, or all of the above?
I think the second part looks pretty strong. I mean, there are 1,100 cath labs in the country, and it's not that one area is assigned a cath lab. You know, if I want to start a cath lab next to yours, just a wall separating you and I'm allowed. Right. So I think this should not be the strategy. It should be area-based decision that this area must have a cath lab. I think that hasn't happened. And that's why when we say spokes, the spokes must follow a particular direction, it probably doesn't happen, because I think there are a lot of competitiveness between the hubs.
Absolutely. Now, the other aspect at almost every Lumen Global, including tomorrow, we have a session empowering the general physician.
Yes.
I have always felt that is almost a double-edged sword. You want to be careful that you want to provide them the necessary information, education about an acute MI, to triage a patient to understand which is a real critical AMI versus a low level, the initial pharmacological medications. Yet there is always a fear that they may want to overextend beyond their ability, but how responsive is the Cardiology Society of India in training the general practitioners?
Yeah, I think the system in India is patient has an access directly with the doctor. Majority of my patients, they would have my mobile number in their phone. Apart from that, when somebody runs into an acute pain, their family physician is very close to them. So this is a system. I think the connectivity between patient and the family physician is extremely strong. And if the family physician is sort of empowered, and this is what Lumen Global has been doing year after year, I think it's going to be of great service. In fact, the Cardiological Society of India does take great pride in sort of spreading out, because we have different states, different branches of Cardiological Society. They run special programs for STEMI, and many of them are educative programs for the family physicians. So they do understand just by symptomatology. You'll be surprised, many of these family physicians, though they may not be able to interpret the ECG, they can take an ECG and transfer it to you, just like any paramedics would do. I've had cases where the family physician has lysed the patient in 15 minutes because the gap between patient and doctor is very small. So let them have the strength of treatment.
And you also have a world-class, inexpensive tenecteplase available from your hometown.
Yes.
Yeah, MCure, I am very familiar. You and I have participated in their educational initiatives. I remember coming to Ruby Hall almost 15 years ago.
Yes, those were our initial meetings.
Yeah.
Yes.
You talked about education of the general physician and the steps Cardiology Society of India has taken. Would it also not make sense to also extend that reach to direct patient education, employing the media?
Yes, I think it does happen not as frequently as it used to happen in US some years earlier. That is why if you see in India we have ST elevation in bigger number compared to non-STEMI kind of situation. Because patient probably waits and ultimately it's an elevation which brings them to the hospital. By the time we have probably lost a big opportunity to treat them in a better way.
Well, I'll take this further and give you my own personal thoughts on it. Why I think delayed presentation is one of the fundamental flaws and the biggest challenge in the country. When the patient has been waiting so long and procrastinating due to a variety of very genuine reasons, lack of financing, lack of transportation, incomplete lack of complete trust in the system, I can understand. And there is always denial of chest pain occurs. I have taken care of 3 interventional cardiologists who were delaying their symptoms. So I can understand that. But what that does is that clearly makes the management of that thrombus difficult, and the patient proceeds on to shock, and it's a much more challenging situation then so one of the major initiatives of both the American College of Cardiology and the American Heart Association in the United States was to focus mainly on educating the patient and decreasing the time to presentation. In India, I think the beauty and the possibilities and the reach of pharmaco-invasive management, I think, is also nullified because of delayed presentation. Because if you are looking at the registry data of Xavier, it was probably, I am forgetting his name, from Bangalore several years ago, that patients were presenting at around Create registry at 6.5 hours.
Yes.
So by that time, no thrombolytic therapy is going to work, and you know, we are needlessly exposing the patient to a very potent drug which may cause bleeding and hypotension.
Very true. I mean, pharmacoinvasive is a good approach. Many say that it's a India-specific approach because reach to cath lab is not there. But the fact remains that whatever we do, do it early.
Right.
And unless we educate the people to sort of react quickly, I mean, it could be a good neighbor who makes a diagnosis because he has heard you give a talk or your presentation in a newspaper. And that is how I think we need to educate. Unfortunately, that component is also not very strong. Like we all know that ACC or American Heart, they took it up on themselves to educate public at large. I think we should also be doing the same thing, though most of us, the cardiologists, physicians, we do take some group meetings, but I think they should be done in a larger scale.
Right. I think there is another sensitive topic I want to get into, Shirish, with your kind permission. It is, I do understand it's a provocative question, and you can choose not to answer it. One of the issues I find in India is a maldistribution of cath labs. And if you take a look at it, 1100 cath labs is a fair amount of cath labs, but the trouble is New Delhi, as an example, has 80 or 90 or 100 cath labs, and Kerala, which is an area I am very familiar with because of my wife being from there.
Biggest density.
Yeah, exactly. And yet you have pockets in the country where there is absolutely no access to care. Can the society do something about this?
The society, to a great extent, in this particular aspect, is powerless. You know, I think society can guide. Society can help government to sort of legalize this kind of issue. Like in a particular area, there are existent lab. Nobody else should come into a particular jurisdiction. I think this the government has to implement. Society has expertise to guide. But the society has not a very strong connect with the government, I feel. I think that we should be strengthening. The government also should see, this is the best initiation, and the society can clearly help government, which is going to reduce the coronary deaths in a best fashion that you can imagine.
Shirish, it's been an absolute pleasure talking to you at Lumen Global. I want to thank you once again for the phenomenal work you did as the president of CSI. I attended the meeting in Kochi when you were president. I can attest, in fact, I have mentioned it to many people in the United States why that was one of the best planned and beautifully executed meeting. And also, just about everything which we talked about STEMI interventions, you did address there. So I congratulate you on that. It's been a lot of hard work, I know, being the president of such a large society, and I think you deserve all our congratulations.
Well, I'm flattered, Samir, but at the same time, we feel very proud that this is something which you have taken up to your heart. You haven't stopped just in Florida or just for US, you've gone globally. I think one person, we always talk of the procedure saving life, but I can to myself tell that if one person have saved life, it's you. Not by actually doing the angioplasty, 9-minute angioplasty, which you do back home, but by stimulating, to instigating to a great extent all of us to do better, better, and better. Save time, save lives. I think you've been phenomenal.
Shirish, you've been very kind, but behind me also are these tremendous people with the Lumen Foundation who all have had a remarkable journey, and it's been a wonderful process of improving ourselves and teaching others around the world. Thank you so much for coming and joining us.